So now that we have heard a range of the talks highlighting the different high-risk group that's outside of the current recommendation for lung cancer screening, I would like to set the stage for our panel discussion by briefly stepping back to frame some of the issue. So we know that current screening guidelines worldwide capture only a fraction of the lung cancers, and a significant segment of these high-risk population are not eligible for lung cancer screening. In our Mount Sinai I-ELCAP study, about 1 in 4 participants in our studies are never smokers and currently not eligible for lung cancer screening. So how can we include these patients or participants into lung cancer screening? Do we need more randomized trials? If randomized trials are not feasible, what kind of evidence do we need to expand eligibility? So if we look at the type of cancers that are found in smokers and non-smokers, we see that in non-smokers, majority of them are adenocarcinoma. So they are typically less aggressive than smokers' lung cancers, which has also squamous cell and small cell carcinoma. So, but once we know the cell type of these cancers, do we expect them to behave differently between smokers and never smokers? In this study that we looked at I-ELCAP's patients in our Mount Sinai patients with non-small cell lung cancer less than 3 centimeter, we used a measure of aggressiveness as the volume doubling time and the PET as UV uptake. After we adjust for age, sex, and also the tumor histology, we found no statistical significant difference between the tumor aggressiveness between smokers and never smokers. So in other words, the tumor biology are very similar, are comparable between smokers and never smokers. And wouldn't we expect the screening benefits to be similar as well? And therefore, should we expand eligibility to these high-risk population? So although we know that for lung cancer, smoking is the key factors for causing lung cancer, but we also hear that a lot of these high-risk population have risk of lung cancer as well. So here I'm just hypothetically have a case of smokers with 20 pack years, and these days a lot of the studies can enroll participants into lung cancer screening by using the PLCO risk model of having a 1.51 risk of lung cancer in 6 years. For these smokers, we have this bar over there. And then we know that a lot of these risk factors, they don't exist in isolation. So never smokers can have multiple risk factors. If we look at these risk factors by itself, they might be less, the probability of lung cancer could be less than smokers. But if a patient have more than one risk factors, it could lead to increase the probability of lung cancer above the smokers. In fact, existing study have found that these risk factors, non-smoking risk factors, they interact with each other and also are additive in some case, which make these never smokers have a higher risk of lung cancer than smokers. With that said, we'll open the panel discussion. So the first question that we have to the panelists is, what type of evidence is necessary to justify lung cancer screening based on risk factors other than age and smoking? And the selected other risk factors included in the current risk factors models. Is it reasonable to require, or are we likely to obtain that level of evidence?
We thought we'd start with an easy question, just to get it rolling. Anybody have any thoughts on this? Doctor.
So from the epidemiology point of view, I think that the landscape of lung cancer risk factors have changed, and the screening has to adapt. The screening guidelines have to adapt to the fact that the landscape has changed. The histology is different. The risk factor, smoking is less prevalent, thank God. So the risk factor population level have changed. So those should be the factors that drive the way breast cancer has a questionnaire that composes age of menarche, age of pregnancy, number of pregnancy. This should be the same, whether you are exposed to something, you live in a certain areas, you have a genetics. There are other things that should go into the composite risk that are different from 20 years ago, even 10 years ago.
I was just going to comment, we have this fixation with the randomized controlled trial, right? That's what drives our recommendations here in the US and the US PSDF recommendations. But those guidelines have been adapted using modeling studies. So it's not exclusively randomized controlled trials, but at least that's where it started. So I don't know that we necessarily need to do randomized controls for every other risk factor or aggregation of risk factors, or if we can use modeling studies, if there's enough good data to be able to adapt or adjust the current screening recommendations to be able to be more inclusive. Can you just go back to that one slide you had with the cumulative? Because I think there's one where you show that everybody else is stacked up. You have the individuals who never smoked all stacked up. Well, the people who smoked also had other risk factors, and it's important that you include that in trying to compare the populations that we just never did a such deep dive for, right? That's, yeah.
Bruce.
Yeah, I agree with Ella's comment on, I wouldn't perhaps call it modeling, but observational data. And one of the big ones for other, almost every other major cause of morbidity and mortality in the US is income. People who are poor have worse outcomes and higher incidence of just about everything. And that hasn't been commented on. I haven't seen the data on that published for lung cancer, but I suspect it's there. And if the goal is to reduce mortality, I think the evidence is very strong that poor people, given the same stage and other characteristics, have worse lung cancer mortality. So it might be a factor that we should be screening people with low socioeconomic status at a lower apparent risk level, PAC years, because they suffer worse outcomes, even though the disease seems to be the same.
Yeah, I'll just also put my my vote in the non-randomized trial bucket, which is I think there's lots of data available through I-ELCAP, for example, that if we, for example, were interested in learning more about the additive or main effect of historical air pollution exposure, we can do that through the I-ELCAP data up to the degree that we have sufficient numbers of never smokers in that population or varying degrees of smoking history. And we can, we can model in people's former exposure, at least according to ambient air exposure. And there are other ways we could layer in other factors like that to look at like the added contribution of those factors. Again, preferable if there's a larger never smoker population in that screening population.
I concur that it would be wonderful to include all the risk groups. I think we're at a point at the moment where we have not got lung cancer screening in the majority of countries around the world. So we need to look at where the evidence is strongest and build the evidence to add on the additional risk, high risk groups as it moves forwards. So I would say that, we have a very solid core data for the smoker population. And we have cost efficacy data to show that lung cancer screening should be implemented for that group. I think once that is in place, we can start to then look at inclusion of other groups. If you look at the Australian and the UK, Canada, they use the multivariable risk criteria. So there is an element of flexibility. They showed initially the cost efficacy. They were able to have a positive start to lung cancer screening. And it's at this point they can then look to add on. And that's a similar way to breast cancer that you mentioned. We need to consolidate in those countries where we don't have national screening first and then move forwards. When it comes to, the evidence, as long as we have the risk equivalence, that we can show that in that group of patients, there is biological equivalence or the tumor acts in a similar way. So if you achieve that shift change, a shift stage change, you will impact mortality. And if you have outcome equivalence, i.e. the impact on mortality, and balancing the risks, there is a very strong case to move forwards for those additional high-risk groups to be included. It would also need feasibility and costing, which is probably an area that needs to be added into your studies as you're doing them, rather than an afterthought to try and gather that information.
I just wanted to add one other comment that Martin Tamamagi, through the I-ELCAP prevention diagnosis detection group, has been funded to do detailed landscape analysis of all the known evidence about lung cancer risks, leave no stone unturned kind of approach to every possible risk factor for lung cancer for which there is data, to try and synthesize it all into one place, so that if you were going to try and develop a risk model, as he's been very good at doing historically, that we could move in that direction, but to really do a very, very thorough analysis of every possible non-smoking related risk factor to be able to potentially move that forward.
So I have a related question. Several of the presentations in the last session, they didn't give us the level of risk, lung cancer risk of the included population. They didn't say, for instance, it represented a 1.5%, 5-6 year risk or whatever, but they showed us the yield, the screening yield, and they compared it to the screening yield from NLST or from Nelson. And their screening yield was the same or higher than the screening yield at NLST, above 1%, say, for baseline. So the population has an increased risk. It's not well characterized in terms of their absolute risk, but we see that their yield is at least as high as NLST. So my question is, do you find that to be convincing evidence that that group should undergo lung cancer screening? Is that reasonable evidence to use, at least retrospectively, in terms of, and then thinking forward, expanding the screening? Is that kind of result sufficient to convince you, yes, that group should have lung cancer screening, if that makes sense?
So I think the one word of caution is all lung cancer the same? I think we know in most cancers, there's everything from cancers that you can live with and will not die of, to cancers that are aggressive and will progress if not treated. So understanding not just cancer diagnosis, but impact of that cancer diagnosis is important. All things the same. And we have, I think the ground glass nodule issue is a real example of that. We have clearly large populations have been screened and have had ground glass nodules, often small, that have been resected and are cancer under the microscope. Now, are those cancers that would have impacted that individual during their lifetime? What's their aggressiveness? Is there a true stage shift, but not just a stage shift for the number of advanced cancers going down, not just early cancers going up when you screen? So some of the other populations that have been studied that do not have smoking as a risk factor, but have other inclusion criteria like family history, a cooking exposure, and so on, I think it's very important to understand that the long-term impact of screening and surgical resection for these early stage lung cancers as to their actual aggressiveness and impact on mortality. So pretty much every cancer that's been screened for has gone through some iteration of this and trying to make sure that there's not overdiagnosis and also not missing, obviously, cancers that would be impactful. And it's a very delicate balancing act because not all our populations are the same in different parts of the world. The exposure profiles are different. So it's almost very hard to say one set of risk factors fits everywhere due to population and exposure heterogeneity.
Any other comments? Yeah, David. Yeah, sure.
Basically saying the same thing. And this issue of the cancer's aggressiveness, and it's something that I think is really important because I think, to me at least, this is the way to move forward quickly. If we can demonstrate that the cancers behave the same way, just like solid cancers that you found in NLST or an I-ELCAP, the solid tumors, if you can demonstrate in another high-risk group that the cancers it's developing are not all non-solids or ground glass, but they're developing solid tumors, and you can show that these behave really radiographically the same way as NLST kind of tumors that are growing at a rate, that have the same kind of PET scan values, these kind of things. I think once you can demonstrate that the cancers are behaving with the same level of aggressiveness, then the only other question is, can you identify them at a high enough frequency to make it worthwhile to do? But it's demonstrating the aggressiveness. And your first order evidence for this is, you look at the staging system, for example, it doesn't even ask, was your 2 centimeter solid cancer in an asbestos person or in a never smoker? It's staged the same way. We lump them together. And I'm sure there's some differences, but by and large, when you're looking for small tumors that are growing at the same rate, if we can start getting to the point where we demonstrate that they're at the same level of aggressiveness, then the only other question, as far as our group is concerned, is can we identify a way to find it at a high enough frequency within that group? Is there something else? Is it a combination of risk factors? So those two things, and that's what Lucy was saying, and I think that's what Ella is basically saying as well.
So anybody else have a comment on that? Sam, yeah.
Yeah, I'm tracking more with what Lucy was implying, that you have to show a little bit of cost efficiency before you try to expand the group of people you want to screen. And I would like to ask the group, does anybody have a ethical or statistical problem with bumping the smokers with COPD to the front of the line?
I don't know if they have it. I found it very interesting when you presented that, because if I understand what you're doing, essentially, you're taking the people with the highest risk of having a lung cancer found and moving them to the beginning of the list, which is really no different than saying these are our screening criteria and these people don't get to be screened at all. You're stratifying based on risk of disease. And if so, from a medical justification standpoint, it seems like a very reasonable thing to do, taking the highest risk people and finding the cancer earlier in a resource constrained environment. Because I think, as you were alluding to, if you had unlimited resources that could screen everybody, you wouldn't have to make that choice. So you're making an informed decision, balancing principles of ethics to try and do the right thing by the population that you're responsible for at the VA. And so I wish it wasn't so that you're resource constrained, was really my thought, not that, and understand that that's where you have to go to be able to save the most lives from lung cancer.
I could have not said it any better. And for the countries that are resources constrained and want to get solid footing on the benefits of lung cancer screening, I think maybe that's the group that they need to start showing that this is feasible and that it reduces mortality.
I find it very interesting in our US health system and a Medicare and a fee for service and Medicaid kind of complex hierarchy of how healthcare is covered is we don't make decisions really on say we have a national budget for healthcare and we're going to decide what gets into the budget or not. We have this heterogeneous fabric of medical decision-making and appropriateness, and we talk about cost effectiveness, but sometimes we don't really follow it. It's more complex. If you have a resource constraint and you're making intentional decisions about what you're funding and what you're not funding, or people will compare childhood vaccinations to cancer screenings and make a decision as a national health system as to what the balance of benefits and harms are into what you choose to pay for. And they're making those decisions based on the resources they have to serve a population, right or wrong in that balance that they choose. And I'm sure they're not easy decisions.
Yeah, I do think that there is an ethical wrinkle here, which is, question is whether the people you're moving to the front of the line with COPD, whether they're likely to receive as much benefit from lung cancer screening as the ones with lesser or no COPD. They have a shorter life expectancy, for example. Now, I'm not advocating sorting, but it is an ethical, I think, an ethical question that should at least be considered.
And we already know that the whole shared decision-making calibration of
Other comments from the audience? Okay.
So moving on to the next question, can we learn from other organizations that expanded their guidelines to include other risk factors?
So I'm the vice chair of the NCCN screening panel, and we dropped years since quit, which is what the American Cancer Society also has done. And so we're trying to move that through our system of care here. So we've been lobbying USPSTF, working with advocacy organizations to try and get them to reopen the lung cancer screening decision. They have decided not to reopen it early. Currently, we don't know what the status is of the USPSTF with things that are happening in the healthcare structure here in the US right now. We also reached out to Medicare to see if they would drop the years since quit, because people have enduring high risk independent of their years since stopping smoking, largely based on the fact that their lung cancer risk increases with age, and they're getting dropped out of screening because they age out, they hit the 16 years since quit. Their cancer risk didn't go away overnight, didn't drop, it keeps going up. Medicare says very, very receptive to the discussions, very positive. I think someone on the team there that we're discussing it has a family history of lung cancer, really resonates to it also at a personal level. So I think they understand what we're talking about. They technically in our country can't do anything until USPS reviews it and makes a decision. So we're kind of stuck in this little bit of limbo with trying to move anything forward because of that here.
I'd say with the use of the variable risk score, it is easier to make these changes. Australia made a choice at launch to ensure that they were able to reach the Indigenous and rural communities, and they actually lowered the age limit for that group because they had data to show that the disease affected those patients earlier. You know, and there are examples in other countries like England, where they've targeted specific high incidence populations initially. So I think, you know, that there are examples where they use these risk prediction models where they can make those nuances locally more easily.
I think there's lots of examples for reimbursement in the U.S. HPV vaccine, I believe, was expanded to include males. The use of TAVR outside selected hospitals, the reimbursement for large joint replacement to outpatient ambulatory surge centers. So I think there's a really pretty large set of examples where that's happened in the U.S.
might not exactly address this question, but just going back to the firefighter example, there's this legislation called presumptive illness for firefighters, and it varies from state to state. But in several states, lung cancer is among those conditions that are included in the presumptive illness policy. Again, this is state by state and it varies. But they're basically saying that if a firefighter winds up at the end of the day with having lung cancer or a variety of other listed conditions, then they don't have to go through the battle of, the legal process of sort of providing justification or compensation that it was, or demonstrating that it was due to their occupational exposure. The presumptive illness laws indicate that, no, you have lung cancer, it's because of your occupation. So I guess I would say, if that's true, and it's not true in every state, but in states where it is true, it seems like those workers should be screened.
So in comparison to the other guidelines, what I see different is that for, let's say, breast cancer, the risk factors are all running in a very narrow range. While here we have one risk factor and then the other. So that's what is playing against an easy expansion, because you have a very unusual situation. So the aggressiveness may address that difference in risk related to smoking. So that could be a way to go, might be.
Was that, NLST wasn't designed to be the be all and end all answer of who should get screened. It was designed to be able to do a trial with people who are healthy enough to be followed, to be able to show a mortality benefit. And it was never intended to be the screening criteria that we would always use. It's just makes it structurally difficult to continue to expand the risk criteria when people look to that randomized control trial, and similarly with Nelson, and say, well, these are the populations, and how do we move from there?
So, I focus on occupational risks, and we don't have a good model, and it's not included in the models. And we know it's an important risk, and we think about how to include it in the models, and it's not easy because we don't really know how it interacts with the other factors in the models. So you can't just insert asbestos exposure or what have you into the model and assume that the other factors' contribution to risk will be unchanged. And yet we're not really ever going to undertake a study of enough people occupationally exposed to get the kind of data we need to develop a model. So it's a problem. We took a very crude approach in our program. We said, okay, you have occupational risk, we're going to cut your smoking related risk and I hope it works out. And in fact, we got a baseline lung cancer yield of above 1. So we felt comfortable. Okay, fine. We're in the NLST range. But I don't know what to do with this problem because I don't see this. We could model it, but it's going to involve a lot of assumptions. And I don't know whether those assumptions would be credible or not. And I'm sure this applies to other risk factors as well. And it applies not just to the US rigidity in approach, but it applies, I think, to the risk factor models used in Europe because they don't include all the relevant risk factors either. What, do you have any comments about that thought?
I agree. It's exactly how you said. Very empirical, and you don't prove that you're right. You just have a result that is satisfactory, but we don't know if it could be better or worse than what you're doing.
I'm not sure if it's going to solve the issue, but I-ELCAP are currently undertaking the handbook on lung cancer screening. It does include looking at different risk profiles and the different risk prediction models that are being used. So that there are members here who are part of that group, but that piece of work will be complete. The first outputs will be midway through next year with a full publication at the beginning of 2027. I think that will be a fantastic tool to use as a baseline. And, you know, it's one of those documents that needs to live and needs to improve as you've got more data. You can include it with the I-ELCAP initial assessment. I think one of the things that's very important about the handbook is if you look at other handbooks that I-ELCAP have done for breast cancer screening, cervical screening, they've been transformed. I forget the word. They have transformed the interest and the prioritization within countries. So I think it's, you know, it will be that building block that you can build all these other risk models from.
So our last question is, if we can demonstrate the type of lung cancers found in these population behave similarly to lung cancers in smokers, and we know that their level of risk of developing lung cancer is the same as smokers, shouldn't that be sufficient?
You know, this fits with this question. The risk models don't require randomized trials either. I mean, we can build the risk models. You don't need the control arm to build the risk model. You can build the risk model just from the screening data. So we'd be able to build these kind of risk models. You should be able to build a risk model in atomic energy workers based on, you know, whatever factors you collected to see if you can identify a group that's high enough risk, whatever that combination of findings are. But I think at least to our way of thinking, we need to separate these. If we can make sure that these cancers are really behaving, that you're not just finding non-solid cancers, but you're finding the kind of cancers that we know are life-threatening and we know that they're behaving the same way, then it's just a matter of figuring out, can we identify a group that has a frequency of those type of cancers that makes it worthwhile to look for them early. And I think that just separates it. It makes it very clear. We now need to build the risk models to identify a high-risk group that has cancers that we know behave in the same way. That separates it. I mean, that's really all these modeling exercises are going to try to do. And they're going to model all kinds of things in the future. I agree with what Ella's saying. They'll be modeling screening at 2-year intervals or 3-year intervals, or you know, there'll be lots of models. But I think the key thing is to understand the aggressiveness of the cancers. And then we can start learning how frequently we can predict, because there's got to be some occupational exposure that's high enough. I mean, it just can't be tobacco, whether it's, you know, arsenic or, you know, something else. I mean, there's got to be other really high risk groups that we can identify that we should be able to figure out, hey, you need to be screened.
David, what's the minimum data set you need for that? I think it's whether someone developed lung cancer and whether they died and then the whatever environmental and other demographic information you can get. I don't think you need a screening trial to create those risk models.
Well, that's your expertise, Bruce. So you can look at all the claims data and
yeah.
So are you saying work backwards?
yeah,
Absolutely. We've got, you know, millions of lives and know who died of lung cancer probably, and work backwards.
If we know their risk factors. Right, if we know their risk factors.
know the risk
But
factors.
you'll know some of them. You'll know demographics. You'll know location. You might know probably income, other conditions, and work backwards. And some of the for example, particulate matter where someone lives is well understood radon exposures.
Dr. Yip, what have you found in all your modeling exercises? Do these risk factors act independently? Can we add them together? You showed that in your example, but do you have a suspicion that that's the case? Have you seen anything else that really is important beyond tobacco and age?
I think they definitely have additive or multiplicative kind of effect together, but it's rare that with all these, it's hard to get a data set that collect enough information in all these different risk factors, and especially like particulate matter. We've been trying to, we try to include that information into the VA model that we're working on, or we worked on. It's a little hard, and then now we're trying to add that information into our I-ELCAP information too. So people move, and how do you capture all those information? So it's just a matter of how we can gather all those data and to build models. And do we need different models for different population and for countries? Once we set a cutoff, maybe different countries can apply different cutoff to decide whether they can enroll different patients.
Right. I'm enthusiastic about the potential of AI to work with such data sets.
I think my one to add on to that is you also need to look at how do you identify them to get them to come for the screening. So it is a big step to, I mean, if you are presenting this to a health system, you need to provide the mechanism that they're going to reach out to that at-risk population and be able to get them to come in.
Right, but other than like active recruitment for lung cancer screening or what, like, isn't that normally how it would work? Like if someone comes into the office and they meet a certain set of criteria for breast cancer screening or, cardiovascular risk workup, then they get referred, right? And you could do the same thing with, if you had a model, right? And you could plug in their residential history, it would give you some information about radon exposure, air pollution exposure, other factors, and then it would spit out a score, what their risk is, and then maybe that would tell you for a non-smoker, here's their risk, modeled risk, and then whether or not that person should have lung cancer screening is, I guess, that's where the debate's going to be, I suppose.
Yeah, I think that's the real question, is building a risk model for lung cancer in individuals who've never smoked.
Right.
That people find would be validated and work and be able to use for that purpose. That I think is the goal.
With that, we'll close the section, and thank you all the panelists.